All right, let's go ahead and get going here. Just a couple of introduction things here, and I'm going to hand it over to Todd for today's presentation. So welcome to Project Echo. This is our current series focused on treating patients with substance use disorders co-occurring with other mental illnesses. Just a couple of quick housekeeping things. I'm Will Schmeckley. I'm a project coordinator at the Nebraska Medical Association. This slide here just states that all those involved in today's training don't have any financial relationships to disclose. And we like to acknowledge our funders. Our funding is grant funding from the State Opioid Response Grant. Those grant funds come to Nebraska DHHS and then are passed on to us to put on these trainings. We like to thank our partners at the DHHS Division of Behavioral Health for helping us make this possible. Your CME certificate. For those of you who have participated in these Project Echoes, this is nothing new. It'll be the same thing as in the past, where you'll get a link to complete a quick evaluation survey. I'll be emailing that link out at the end of this training later this morning. I'll also post that link in the chat towards the end of the day. So just complete that quick survey, and then your certificate will download automatically. Pretty simple. For those of you who are new, Project ECHO stands for Extension for Community Health Outcomes. Our ECHO is focused on topics within the realm of pain and substance use disorders. So these are trainings and consultations. We have about a 30 to 40 minute didactic session. Today, Todd will be doing that, and then we have time for case consultations, questions, and things of that nature. It's sort of a hub and spoke model. We've got a hub team of 6 experts with great experience and knowledge on these topics for you to consult with, and we can make consultation time available outside of trainings as well. Just contact me and we can make that happen. As I mentioned, our current series is focused on treating patients with substance use disorders co-occurring with other mental illnesses. You've all seen the schedule. Just a reminder, we do these trainings in sets of 4. And with that, I'm going to let our ECHO team introduce themselves. Here's who they are. I'm going to stop sharing my screen, though, and let them talk. Let's see. Janet, would you like to introduce yourself first?
Yeah, hi, I'm Janet Bernard. I'm a retired family practice doctor, have been treating opioid use disorder since 2008.
Thanks. Gail, would you like to go next?
There we go. I'm Gail Keller. I'm a nurse practitioner down in Fall City, Nebraska. I'm a psychiatric mental health nurse practitioner, so I treat mental illness and opioid addiction.
Thanks. Ed.
Yeah, good morning. Ed Kaiser. I'm a nurse practitioner in Omaha, Nebraska here. Have been working with substance use disorder, prescribed Suboxone for the last about 5.5 years.
Thank you. John, would you like to introduce yourself next?
Yeah, good morning. I'm John Massey, and I'm a pain medicine physician in Lincoln primarily, and also a clinic out in the Panhandle and other places in the state. Good morning.
Good morning. Stephanie.
Hi, I'm Stephanie Bennington. I'm a psychiatrist in Omaha with a special interest in substance use disorder. Nice to see you all.
Thanks. And Todd, I'll let you introduce yourself and start your presentation.
Good morning, everybody. Todd Stull. I am a psychiatrist and have worked in the area for a long time. All right, can you see my slides?
Yes. If you're able to turn on the presentation mode, that looks great. Yep.
How about that? Is that good?
Perfect.
All right, here we go. All right, so today I'm hoping to make this kind of practical for the intersection between substance use and psychiatric disorders or mental illness, because it's a common theme that presents, especially in primary care. And I really believe that most types of mental illness can be managed in the primary care setting. Obviously, there's some exceptions due to complexity or time or what have you. But I want to make this practical if at all possible. Remember that most mental illness starts, not all, but most starts between the ages of 12 and 25, and most substance use disorders start between the ages of 12 and 25. And so if we catch it early, we can change the trajectory of what takes place. Take-home point and practical point, I think, is that there are 4 major determinants for outcome for substance use disorder. One is commitment to some type of program, whether it's seeing a counselor or outpatient program, or its length of time, though, that someone is committed to a program. That the second thing to think about is untreated mental illness. That's where we're really talking about today, is substance and mental illness. The outcomes are considerably worse. So treating comorbid or co-occurring conditions is particularly important. The third thing is then that influences outcome is having a network. That support system, your go-to team, somebody you can kind of turn to. And the fourth thing that influences outcomes are replacement activities or behaviors. So doing something else other than, getting caught in the cycle of a trigger or something that may cause you to go use again. So having said that, here are our objectives today, and each area I'll bring it up again so you can see it. So we'll start with the epidemiology, and then we'll progress. And we're not, because of the length of time, some areas will be covered a little more in depth than others. This is just a graph showing the progression of overdoses in the United States in the last basically 8 years, where the numbers have gone up, largely influenced by evolution of change in the opiates that are used and the use of primarily sedative hypnotics and benzodiazepines with the opiates. One of the misunderstood things about the benzodiazepines is pure benzodiazepine use disorder by itself is not very common. But you'll find that a number of people that are using other substances, especially opiates, will use or the stimulants will use a benzodiazepine. So the numbers continue to go up, and this is partly driven by combination and largely driven by fentanyl being either used or laced with other substances. In Nebraska, when you compare, this is 2022 to 2023 snapshots of what are the predicted deaths related to overdoses. You can see the numbers are pretty similar, a little higher and predicted from, that was predicted when this was made, which was early in the year in 2023. But the numbers are turned out to be a little bit higher, as we know. So small percent change compared to other areas in the country that are shown in the orange or kind of the lighter, the orange colors or brown colors. The numbers are considerably higher and can get up into the 20s and 30s and 40%, especially like in the Northwest. So what occurs together? Most common substance problems together are alcohol with another substance, including nicotine. But then alcohol or nicotine often are a part of mood disorders such as depression and bipolar disorder. Panic disorder with agoraphobia is very common. Trauma and related kind of disorders such as PTSD is very common to have a substance use disorder. And we often overlook the effects of personality. Remember that 10 to 12% of the population has a personality disorder. It may be mild or moderate or severe, but personality disorders often are the driving force for maladaptive kinds of behaviors and coping skills that lead someone to, for example, being depressed. And this talk isn't about depression, but I want to put a point in that if we're all under stress, and the stress is high enough, our compensatory abilities start to dissipate. We don't do as well with managing things, and we tend to either have physical symptoms, which are manifestations of our emotions, or end up just frankly feeling overwhelmed or anxious or depressed. And that sets many people up, especially if they have a predisposition to have a substance use disorder. So if you treat the depression in that case, or the anxiety, it's not going to help someone develop coping skills. In other words, if a personality problem is the root cause, you may be able to dial down the intensity of the symptoms, but the medication won't help them to develop the skills they need to manage their life. That's a separate process. If we continue with the epidemiology and the data, substance use disorders and psychiatric illness often occur together. So I just kind of summarizing the top part of this slide, you can say someone who has a substance use disorder, 40 to 50% of them will have a comorbid psychiatric diagnosis. Whereas if you reverse the situation and you say someone who has a mental illness, about a third of them will have a substance use disorder. And so they are commonly happening together. If you look at some of the specific mental illnesses, excluding nicotine for people that have schizophrenia, many of them, 50% of them will have a substance use disorder. If you include nicotine within that, now you're in the 80 to 75 to 80%. And nicotine is often overlooked, so I don't want you to think I'm overlooking it. I think it's really important to remember that 8 million people worldwide die as a result of nicotine, and 500,000 year in and year out in the US die as a result of nicotine. 35% of people that have an anxiety disorder will have a substance use disorder. So it's pretty high. And you can see then PTSD is pretty high as well, depending on the extent of the trauma. So if you look at just some of the other data, 14% of the population in any given time, this is snapshot in 2020, has a substance use disorder, and 21% has a mental illness. That's an acute mental illness. That's the A and the AMI. And then 32% have acute mental illness and or both, and again 46%. So I've kind of told you those numbers. I'm just summarizing. What do we know about this though? What's important? The more severe the substance problem is, the more likely that they're going to have a psychiatric diagnosis, and the more likely they're going to attempt suicide, especially with bipolar disorder. So a large percentage of individuals that have manic depressive illness or bipolar disorder, same thing, will have a substance use disorder. So it's important to think about that condition in particular for having a substance problem, because it's a major comorbidity. Now, this is a little bit complicated. I'm going to summarize this slide. This basically says, what's the odd ratio of you having another problem if you have an alcohol use disorder? Well, the most common kind of comorbid problems for people that have an alcohol use disorder are other drug problems, including, methamphetamine or, marijuana or opiates, but also nicotine. And then you can see I've talked about bipolar, and there's, different types of bipolar, and there's a high rate of having odds ratio of having bipolar with alcohol, very high, as there is with panic disorder, and then antisocial personality. And I've talked about antisocial personality. It's the strongest associated genetically driven or linked genetically of the personality disorder. So you'll find that many young men that develop personality disorders, and it's more common in males, will have conduct disorder to begin with, and their fathers have antisocial personality. How about the odds ratio for if you have a drug problem and developing something else? Well, again, there's that association with alcohol and nicotine, same kinds of disorders. So if you have a drug disorder, you're much more likely to have a co-occurring or coexisting alcohol problem, bipolar disorder, panic. It's the same group, right? PTSD falls within this as well, and antisocial personality. So it is pretty common. If you go back to Mark Shuckett, who spent a lot of his career looking at studies of alcoholics, this is one study. We want to, I want to illustrate, and I want everybody to understand kind of from this data of 500 or 5,000 alcoholics, 15% had independent depression. And I'll talk about what independent depression is here in a minute. and roughly 25 or 26% had substance-induced depression. And you approach those two situations different. The individuals that had substance-induced depression had more severe alcohol problems and more likely to have sociopathy or antisocial personality. Independent depression, this comes from your family history, more likely to run in families that have mood disorders. So if you have a substance use disorder and you have bipolar disorder, what's the chances of you having, what's the chances of the substance being present or being a disorder? It's almost 60% for most of the studies, sometimes even a little higher for alcohol. For bipolar patients that have bipolar disorder, 37%, roughly between 35 and 40% will have a drug disorder, and nicotine is pretty high. And there doesn't seem to be any differences in this case between men and women developing a substance use disorder. If you look at PTSD or post-traumatic stress disorder, 34% of individuals that have PTSD have a substance use disorder, and it tends to be more common, a substance use disorder for women, that 5 to 12 times more common in PTSD for women to develop a SUD or substance use disorder. And suicide rates are fairly high in this group, and when you add alcohol or other substances in, it doubles the rate of suicide risk. All right, so let's talk about screening a little bit, and I'll mention a few other points along the way. And this is just about screening for suicide and homicide. I put in, the idea of Columbia Suicide Screening Rating Scale, just for those of you that are interested in what's a standard kind of scale. It's more important to just have a discussion around it. It's more important to bring it up, and especially if there's any element of concern, given the risk for individuals who may be coming in and presenting and you can't quite put things together, or you're concerned about either their depression or comorbidity, or having especially using opiates or benzos. And so it's most important to bring it up. You can obviously bring up other things about, do you have a plan, or have you done it before? What would be the means? Is there a family history? All of those are kind of risk factors for suicide or, homicide. Has there been aggressive behavior and so on? So it's fine to use screening tools if you want to. It's often easier just to start a discussion with the patient and then move on if that's not an issue. Well, how do we separate independent? So that's the next area. It's substance-induced versus independent psychiatric diagnoses, because this is really the key element here of the talk. Independent psychiatric disorders is you can't easily, unless you have a really good history, confirm the diagnosis when someone's in withdrawal or intoxicated. Again, it's hard to know that unless you have a clear history. So you need for them to be in a drug-free state. You need a longer history and collateral history, if at all possible, and past history. So that's for the independent to be able to determine that. For substance-induced psychiatric disorders, they often occur within 30 days and only last up to about 30 days within the substance use. So someone quits using and it's substance-induced, within 30 days, often the symptoms will get better. Substance-induced conditions can be mimic psychotic disorders, mood disorders, whether it's depression or bipolar, anxiety in itself, and often maladaptive coping skills or personality disorders. So just be aware that there can be an overlap or an induction from a substance. So when you think about substance intoxication or withdrawal, the stimulants, the cannabinoids, the hallucinogens can mimic commonly mania or schizophrenia. The sedative kinds of things, alcohol, sedative, hypnotics, can mimic depression or anxiety disorders, either induced or in a withdrawal state. Psychiatric disorders, you'll find that the symptoms or the condition often antedates or precedes the drug use, and you have that history. of knowing, or someone has been free of the substance and they're still continuing to have symptoms beyond a month. I use, 3 to 4 weeks is kind of that timeline to say, gee, they haven't used anything in 3 to 4 weeks. I'm pretty confident of that, and they're still having symptoms of depression or anxiety. It probably means they have an independent psychiatric diagnosis. And then if they have a family history of it too, that's also an important consideration. So what within substance use and within mental illness, our vital signs are our screens. And many of you have heard me say that, but our screening tools are really kind of our do we need to do something or look into this further? Just like if you had a elevated blood pressure, that may generate, one response if it's mildly elevated versus something that's more severely elevated. So these are just some screening tools that you can have the patient or someone in your staff kind of administer to them for ADHD. We'll have a talk about that a little bit later from Stephanie in more detail, around depression and anxiety. And there's moods rating symptoms as well, and tracking for bipolar disorder. I'm just giving you some ideas here about common screening tools that you may want to consider or you're aware of them and you want something. The most commonly used are obviously for depression and generalized anxiety. So there's all kinds of screening tools for depression, whether it's a PHQ-9, and all kinds of screening tools for anxiety, whether it's a GAD-7. None of them are more robust than any of the others. So if you want to, if you're like, oh, I like the Beck for both anxiety and depression as a screening tool, that's fine. I mean, or Zung or Montgomery-Åsberg, whatever, it doesn't matter. It's the idea of doing the screen and something that's convenient for you. So what do we do when it comes to managing common co-occurring psychiatric conditions and disorders? Okay. Substance-induced disorders typically get better or improve when someone becomes free of the substance, and often psychiatric care or additional psychiatric care is not needed. It may be for the substance use disorder, but if it's a substance-induced psychiatric condition, they often get better. If it's an independent psychiatric disorder, meaning they have a substance use disorder and a psychiatric disorder, treatment of comorbidity is particularly important. Remember those 4 things that determine outcomes: length of time of treatment, treatment of comorbid psychiatric and substance problems, the network, and replacement behavior as well. This is the treatment of the comorbidity, and treating them concurrently or at the same time. Often the outcomes are better. So when you think about the co-occurring conditions that we've been talking about, whether it's anxiety or a mood problem like depression or bipolar or ADHD, insomnia is often overlooked as well. Insomnia is a major trigger for relapse to a substance use because somebody wants to sleep, or it is often a trigger for somebody, for example, who's sleep deprived, to develop a manic episode, or even have problems with worsening of their anxiety. And you will find in that, and Stephanie, I'm sure we'll talk about this, that ADHD and not only goes along with insomnia, but people that are not sleeping well can look like they have ADHD or anxiety, same thing, right? And so you need to make sure you're understanding kind of some of those nuances a little bit so you're directing your treatment the way you want to. So the idea is to integrate treatment when someone has comorbidity or co-occurring problems, with sobriety being kind of one of the most important things. You can certainly work and use harm reduction if there's an issue, but you ideally want to get to kind of a state where someone is not using their substance and treating any kind of withdrawal symptoms they may have in the process. The relationship is kind of the key. So I put psychotherapy as a key, but it's really that doctor-patient relationship that's the key, and the follow-up, the willingness to talk about, hey, how you doing in the follow-up. So when we think about psychotherapy, and this is not meant for you to be doing it in the office, but I will tell you, you're doing probably more of some of the basic things with cognitive therapy than what you think by if you're forming a relationship with that patient and giving them some basic skills around maybe how to relax or how to reframe their thoughts around some of their struggles, or getting them to think about maybe there's different ways to think about this or frame it or conceptualize it, and helping them to maybe proceed with difficult strategies to communicate with difficult conversations and so on. So those are, when you look at CBT, we always think about, okay, what is there a trigger? What's the behavior, and kind of what's the consequence? And then all of us have these things called ANTs, right? ANTs are automatic negative thoughts, and automatic negative thoughts generate an emotion that generates a behavior. Well, if you can start to help the individuals you're working with, just take a brief, short period of time to look at their automatic negative thoughts, they're often distorted or off. They're often overlooked, and they just assume they're true, when in reality, they're not always true, or they're partially true. And so if they can look at those a little bit differently, that can make a huge difference. Pharmacotherapy often begins with the use of, if you're going to use medicine with a non-controlled or scheduled medication, and for whatever the condition, whether it's anxiety or depression, and it often takes a while to respond with some of the non-controlled substances. And again, the therapy is often best to be used with. Now, you'll see that someone who has cognitive behavioral therapy, it can influence their response to take medicine and be compliant with medicine, just like medicines can dial down the intensity of the symptoms, so that then they can use some of the coping skills or strategies they're acquiring or learning in cognitive behavioral therapy. So they influence each other. The therapy influences the medication and vice versa. So what about benzodiazepines? Let's talk about benzodiazepines, because there's a lot of, I think, misunderstanding about benzodiazepines. Benzodiazepine use disorder by itself, that number is relatively small. It can occur, and commonly can occur, with the use of other substances. And there are clearly people that have substance use disorders that can benefit from being on a benzodiazepine, but you have to be very cautious. So some people say, oh, you should never use a benzodiazepine for someone who has a substance use disorder. There are exceptions kind of to that. Let me go on a little bit of a tangent here, because it's a misunderstood thing. So we talk about substance use disorders being chronic relapsing conditions. Okay, let's take alcohol, which is one of the 90,000 people every year die as a result of alcohol. The majority of individuals that have an alcohol use disorder, it's not chronic and it's not relapsing. 93% of people that have abusing alcohol or develop the disorder will get better over time. And in fact, 70% of those, it just kind of goes away with whatever the person's doing. So it's not reoccurrent, it's not chronic. There are individuals that have more severe substance use disorders, and that group you have to be particularly cautious with when you're using benzodiazepines, the more either moderate or severe. So just think of it that way. Not everyone should be excluded, but at the same time, we have to be particularly cautious about benzodiazepines. And if you look at some of the larger data or the studies from their treating individuals that have anxiety, antidepressants really don't have a benefit over the benzodiazepines for that group that does not have a substance use disorder. And so there's still a place for them in some cases. If you look at the comprehensive kind of literature review, demonstrated efficacy for benzos in GAD and panic and so on, and we've known this for a long period of time. The original studies that were done looking at treating generalized anxiety disorder used 2 to 6 milligrams of Xanax. And that was the dose that was effective. And now in this day and age, people say, oh my goodness, I'd never use that amount. Remember, Xanax or alprazolam has an FDA indication for treating depression as well. That's from a long time ago. So there is an overlap. So, if somebody has a moderate to severe substance use disorder or a sedative hypnotic disorder, I would not use a benzodiazepines. And in general, as a general rule of thumb, I would not use a benzodiazepine. So I'm not saying, oh, we should put people on benzos, but there are exceptions to that. There's not a lot of data to show that around treating co-occurring anxiety and substance use disorders together. But we know that CBT has some effects on substance, but it's hard to assess the extent at this point. And medicine has some effects on anxiety, but not so much probably the substance use disorder. So I'll leave it at that, given our time limitations. You will have access to the slides, but treatment of comorbidity is pretty important, and integrated treatment is kind of the key when there's co-occurring problems for the mental illness and the substance. So combining treatments. How about bipolar disorder and alcohol use? Drinking typically follows an onset of mania or mixed mania or dysphoric mania or rapid cycling, right? So it usually follows. And there's the greater the severity of the issue, the greater the severity of the substance use, or the greater the severity of the mental illness, the more likely there's going to be a suicide attempt or gesture. Relapse doesn't tend to occur with substances as much when someone has bipolar disorder and they're either euthymic, their mood's normal, or they're depressed. It's more likely that there's going to be a relapse when there is mania or mixed mania. Lithium doesn't tend to work as well for individuals that have alcohol and bipolar, so Depakote is a better choice, right? But if you're looking at someone who has a substance use disorder that's not alcohol, with bipolar, lithium should work along with some of the other agents. So that gives you an idea of kind of treating that. Now, I haven't talked about depression so far. Depending on if there's other cases presented today, we may not get to that, but I do have a case presentation if we don't to talk about depression. Before we do that, I want to talk about insomnia. Insomnia is a significant kind of component of many psychiatric disorders and many substance disorders. It's either a part of the, for example, you'll find that individuals that have depression have difficulty falling asleep or staying asleep or early morning awakenings. Well, it's true of anxiety that there's difficulty falling asleep and so on. Well, it's true of substance-induced conditions or substance withdrawal conditions that disrupt sleep. And so sleep is a really important issue that co-occurs, that can also be a trigger for development of worsening of a condition, whether it's a substance-induced condition or a substance use disorder or a psychiatric disorder. So we tend to want to think about treating this, depending on the scenario initially, by basics of sleep hygiene. So stimulus control therapy, what time you going to bed, trying to make it routine, temperature in the room being cooler, dark in the room, free of kind of lots of loud noises or stimulating things or, lights and so on. And some people that really struggle, the initial kind of first line treatment is to reset their clock. And this often comes from sleep restriction and going to bed later and trying to reset the clock and getting up at the same time and not, napping during that day and so on. If that doesn't work, there are obviously second line kinds of treatment, whether it's use of light therapy and what's called 10,000 lux lamps, which is again non-medication. You can get one of those lamps that like at Menards. They're fairly inexpensive. You can get them online. They're a little more expensive. Then there's the relaxation kind of training. For those of you that are familiar, the Benson relaxation response. Herb Benson was an internist that came up with that. But there's other kinds of ways to help self-regulation or using apps or noise or white noise to help people wind down. And then medication is typically a second line or treatment. Not always, because sometimes you have to go to that earlier. Other than Neurontin or gabapentin, the typical things we would think about in treating insomnia for someone who has a substance use disorder or a co-occurring psychiatric problem would be to use like Deserel, which is trazodone, or Remeron, which is mirtazapine. Remeron or mirtazapine, in my opinion, is often dosed too high for people and it makes them sluggish the next day. And so if you give them an adjustment period of either a half a tab or a quarter of a tablet, they're more likely to be compliant with it. It can often help with sleep and anxiety as well. And then you can adjust the dose over time. Obviously, the melatonin agonists that you can, and many of these you can get over the counter, or prazosin if somebody has PTSD. It can help with kind of the autonomic arousal and help with the sleep and the nightmares as a part of PTSD. Now, the final slide before we're done with this part is just a reminder that integration is kind of a key element. And for those of you that are interested in learning more about kind of some of the options for integration, the NMA has a project that's going on right now, and Will can you can reach out to Will, but it's helping primary care clinics primarily in the state of Nebraska find what they're looking for mental health providers or to treat mental health and substance problems into their clinic and integrate treatment. So that's one way to think about this. But the other point of thinking about integration is treating comorbidity and integrating treatment together, because it's particularly important in this process. So that's really where I have ended the regular slides. Are there comments or questions or points that need to be clarified? And if not, then we can move into somebody's brought a case. Anybody have a case or discussion they want to talk about? If not, I'm going to make a couple points. Well, and I'll give before I move into the case that I brought that I did not include, but I want to include here. So, if you think about our echo and it's around pain and addiction, one of the things that comes up is how do I, if somebody's having muscle spasms, what should I use? Can I use Soma? Is a question we've been asked. Well, I think it's okay, but remember that Soma has the major metabolite in it has a longer half-life, and the major metabolite in it is bromate, and it works at the GABA receptor. So it's like a benzodiazepine, and sometimes people can get addicted to it as well. So just remember that there's probably better options other than use of Soma. Another question that's come up about overdosing is related to a newer substance that's you may or may not have heard of, but it's gaining a lot of steam, called xylazine. It is an alpha-2 agonist that weakly displaces opiates at the opiate receptor and has some analgesic properties. When combined with either opiates or benzos or other substances, it's often so potent because it's used as a horse tranquilizer in veterinary medicine that it results in death. So we're finding more and more people using our drug screens across the country with xylazine in it. All right, so anybody have a case? Let's move into one here. And there's something in the chat here, looks like. Yes, great comment in the chat, which is quite concerning, and that's the use of benzos in the elderly or geriatric population, and falls and hip fractures, and not to mention the long-term effects of benzos. There's mounting evidence to show that it can lead to further either development or further cognitive impairment, in addition to balance problems. And then if you add a benzo I'm sorry, if you add an opiate to the benzo, it really complicates things. So you have to be very, very cautious about using opiates in the elderly population, benzodiazepines in the elderly population, and certainly the combination in that population. So I don't want people to think I'm casually recommending that we use benzos. That's not my point here. Let me frame it differently for you. What we did with the opiates is we went from let's check everybody for pain as a fifth vital sign, and if people are struggling, boy, we better put them on opiates, to now the pendulum swung the other way. Oh my goodness, we can't have people on opiates. It's a terrible thing, and so on and so forth. And there's some people that, given the nature of their medical problems or their condition, they may need to be on whether it's chronic pain or end of life kind of care, or maybe other chronic debilitating conditions, right? That may need to be on an opiate and can best be managed with an opiate. Just like abruptly stopping their opiate often leads to not only withdrawal, but then they start seeking it, and you run into either an opioid use disorder or an overdose, and that can be, result in death. So that's kind of my point with benzos. There's an element of kind of common sense and thinking around, should I use a benzo here? And when in doubt, probably steer clear of it unless there's a clear indication and you're very comfortable with it, and there's not a significant substance use disorder, or you get into the geriatric population as well, and you have to be particularly cautious with that. So all right, so Mr. S, does anybody have a case they want to talk about or present? Okay, this is a 55-year-old guy that has hypertension, and you've been treating for many years, and had a right hip replacement, and he's been feeling down since his surgery 3 months ago. With his energy is low, and he's not sleeping well, and his appetite's not very good. And you know that he's had 3 previous episodes of depression, one in his 20s, and then age 33 and 46. So what you want to do initially is clarify, kind of ask some questions and clarify kind of when it started, when the depression or the symptoms of low energy and being down started. And remember, all psychiatric diagnoses, it's not just symptoms, but the other part is functional impairment. So you want to inquire, how's this interfering with your life? That's true of every psychiatric diagnosis. So, and you want to make sure there's not been a psychotic episode or a manic episode. And then, is there a medical kind of condition that would make him depressed? Is he anemic? Is he having thyroid problems? Or, you want to rule out any medical kind of causes that would generate a symptoms of depression. And in addition, you want to make sure you're not missing other substances involved, or other substances that you're not aware of, or medications and prescriptions that may interfere with someone's mood, right? And then back to that, should we screen for suicide, and thinking about, is there a risk here? Does he have a previous episode? Does he have a previous episode of substance problems? Is there a family history of suicide? Does he feel worthless, useless, hopeless, that sort of thing? And just getting a flavor of those sorts of things. And remember, as I go through this, there's not an expectation that you're going to be in the office going through every single detail that I'm talking about here. This is more of a detailed or comprehensive approach. And I fully recognize when you're in a clinic and you got lots of, if you're a family physician in a clinic and you're seeing lots of people, you're not going to be able to go through everything. So this is just giving you some kind of the basic ingredients that you may want to cover, but some more detail to it. So as you are thinking about and asking about depression, you're asking more about it. He says, he asked you for a prescription for oxycodone. Remember, surgery was 3 months ago. And as you're talking to him more, he says, well, he's been taking oxycodone more than prescribed, and up to 10 or 15 10 milligram tablets a day. And he's getting it on the street, and he's snorting it, and so on. So then he says, well, before his surgery, he began to feel down, and It got worse after his surgery, and he's concerned about returning to work as a construction worker. And he said that when he uses Oxy, it kind of numbs the emotions, the feeling of being down and discouraged and hopeless and so on. And so you inquire further, and you want to figure out about kind of his reasoning for why he's using and so on, and any triggers, because triggers are important to think about. And he tells you along the way that in his 20s he was dependent on heroin, and then he's been in remission for over 30 years, but he was using it in his 20s. So you say, okay, gee, I think he's got an OUD, opioid use disorder, and he says he wants to stop using Oxy, but he has terrible withdrawal. And so you put him on buprenorphine, initiate that in the office, and you can start that without, start the buprenorphine without getting any blood work and so on. But you identify some symptoms of depression ongoing for 4 months, including kind of low daily mood and anhedonia, and some of the common things you would think about when it comes to depression, weight loss and rumination and guilt and so on. And he's been isolating himself, and he says, no history of mania, no history of kind of psychotic symptoms, and you're not aware of any other substance problems. So you're getting these in the history. Those are the basic things in addition to the suicide, right? Or asking about or inquiring about. And so with somebody who has opioid intoxication, this is just kind of, what would they look like? Well, apathetic, they can be dysphoric, psychomotor kind of retardation or agitation. Their memory or their cognitive abilities are impaired. Whereas the withdrawal, they have autonomic hyperarousal and sleep problems and can be dysphoric. And so those things the withdrawal can look like depression. What would suggest a mood disorder were prior episodes of depression beginning in his 20s, right? 30 to 50% of people that have had a previous episode of depression will have a second episode. The point being, the more episodes you have of depression, the more likely it's going to be a recurrent illness unless you get treatment. So, and then, has he had depression in the absence of a substance use disorder? The answer is yes. He told you that from a couple of the episodes when he was 33 and 46. And the depressive episodes may have been related to not only prior to, but he may have been self-medicating to numb out or feel better around the use of his opiate. And so you think, okay, he probably meets criteria for both major depression and opioid use disorder, given the history and the material that you have. And it's best, as we've talked about today throughout our discussion, to treat both conditions. Untreated, it really leads to often relapse of the substance, untreated psychiatric or mental illness. And so you have to think about what are the factors that would lead me to say I want to treat both. Well, we've kind of gone through some of those, and that's clear, independent kind of separation of substance problems. But then the severity of symptoms puts someone at greater risk for not only relapse, but suicide and potentially using another substance. And so you say, okay, after, if I bring him back in a few weeks, should I wait to treat him then, or should I treat him now? And you say, no, I'm going to use buprenorphine, and I'm also going to treat his depression because I think there's both conditions that are occurring together. So that's kind of a summary. It's a common case. I saved the depression for the end because it's such a common occurring condition. Anxiety would be the other thing that you're going to see a lot of in the office. So that gives you the kind of overview of independent and substance-induced psychiatric conditions, with the most common conditions being mentioned, and some basic strategies to sort it out and the separation and the treatment. If it's not, so if it is substance-induced and there's not really a substance use disorder, the focus is on the psychiatric condition. If it is comorbid or there's an independent psychiatric disorder, then the focus is on treating both. So thanks for being here today. Other comments, questions?
Thanks, Todd.
Yeah.
Yeah, we have a couple in the chat. I think Kylene may have wanted to ask a question. If you do, Kylene, you can unmute now and ask it. Otherwise, we can go to a couple in the chat. Okay, maybe not. Yeah, Todd, do you see those in the chat? Let's see here.
I do. So there's the beers list. Thanks for bringing that up. Ginger, may be a good reference for treating older adults. So you can look that up online. So please refer to that. Can you talk about the use of naltrexone in small doses for anxiety and depression? So there is, let's go back to the idea of microdosing. And I think some of you are familiar with the concept of microdosing. If you're not, look in the news now and you're going to see microdosing with magic mushrooms and treating anxiety and various conditions and things that are going on. Microdosing is also a part of use of buprenorphine or Suboxone as a way to initiate or induce somebody onto the medication. There is some data that suggests that the idea of microdosing with naltrexone can have an effect on individuals that have a mood disorder and improving their mood, or a anxiety disorder, and especially probably captured within this group is the comorbid substance use disorder with a co-occurring psychiatric disorder. And it may be a reasonable consideration, especially if somebody has an alcohol or an opiate use disorder where you find more merit. Remember that when we're blocking the opiate receptors and having an effect on opiate receptors, that's the initial effect on whether it's a mu receptor. There's various types of opiate receptors. And then there's starts to be downstream effects on dopamine, on GABA, on other neurotransmitters that affects things like sleep and mood and anxiety. So the naltrexone at smaller doses has been found to have some beneficial effect for some people that may have anxiety and depression. And there's some merit in considering the effects of it. Let me give you another analogy. So before it was really talked about much and explained much, and I saw it kind of firsthand years ago when I worked in the methadone clinic. There were individuals that would come in that would I could get enough history and to say, you know what, they had not only had depression, but they had an opioid use disorder, and we put them on methadone. And because of the mechanism of the way methadone works, it's a little bit different than some of the other opiates. It would treat their opioid use disorder, but it would also treat their depression very commonly. They'd be like, I'm not depressed anymore. And it wasn't that they had a substance-induced depression. It was an independent depressive disorder. And so we found that tweaking, if you will, and that's my words, to some of the receptors can have an effect on emotional tone or states. And in this case, we're talking about naltrexone. So next comment is how to remember that depression is as serious as a heart attack, and not uncommonly people that have atherosclerotic. So the big killers in our country all are associated with mood disorders, especially depression. So atherosclerotic heart disease, somebody who has a heart attack or peripheral vascular disease, more likely to develop depression. But depression can be serious in itself, and untreated depression outcomes are not as good for people that have medical problems. Next major cause of death in our country, cancer, largely associated with depression. So outcomes are not as good. So not only comorbidity needs to be treated in those situations, right? But depression in itself can have a marked detrimental outcome on functioning. Let's talk a little bit about depression briefly in this context, because I think it's important, and then I'll move on to the next question. Depression has really three components that often are not thought of. There's the psychological symptoms. I'm sad, I have anhedonia, I feel hopeless, helpless, worthless. Then there is the physical symptoms. The physical symptoms are change in sleep, appetite, and energy, those kinds of things, and sex drive, very common, right? And then there's the cognitive symptoms, which are often underappreciated. The cognitive symptoms are my brain doesn't work as well, I have brain fog, I can't make decisions, my memory's not as good, and so on. And so all three can have really significant functional impairment. So point well taken when you can say depression, depending on the severity, can really lead to significant problems. Where in Nebraska's medication-assisted treatment centers, I'm going to save that one and we'll come back to that. Many healthcare providers are now providing medication-assisted treatment.
That's
the answer to it. Yeah.
I tried,
Thanks, Janet.
I
Yep.
tried to answer it.
Yes,
Okay.
thank you. Yep. So it's already been taken care of, is that there are more. Thank you, Janet, for doing that. Other comments or questions or feedback? Feedback would include topics people may be interested in as well.
Todd, I think that was a really very, very good overview. It's a lot of material to try to get in there, and I know how hard that is. I think as an old family practice doctor, it is so important, you know, that ongoing relationship with your patient is so important. And you have months and sometimes years to really get to peck away at their history. And I do think that so many of these, you know, you have that initial intake, it can feel so overwhelming. If you can just figure out a way to get the patient to keep coming back, you can have a crack at trying to sort this out. And it is very hard. And I wish I had a person like Todd down the hall, because it is hard to sort it out. But a lot of times with persistence and repeated visit, you can kind of start to get clues at what's going on. And you also have the option to try a few things. So many people that have these co-occurring things, not by means all, but they often don't have consistent caring people in their life. And you can end up providing that, which doesn't sound like much, but it can be way, way, way huge to someone who's never had it.
Great comment. And I'll echo it through the most robust study about health and well-being in aging, called the Grant and Gulag study. It's a longitudinal aging study. It went on 80 years. It looked at a number of variables in two cohorts. One kind of a middle to upper socioeconomic group, and the other a lower socioeconomic group. And they followed these individuals for 80 years. And they looked at all kinds of variables in terms of what determines outcomes and how people do in terms of quality of life and wellness and health and so on. And there were two things that rose to the top in this study that were the most robust factors for wellness and health and so on. Number one was, and they're both related to relationships, just like what Janet said, so that's wonderful. So I apologize for the dog here. Both related to relationships. One is love, and the second is not losing love. That's how strong love was within this context. So love and not losing love were the two ingredients that emerged to the top. Really, really important. There were other things that were important, but not as important as those two components. And so thank you, Janet. Wonderful comment.
I wanted to bring something up that I wanted to get your opinion on, Todd. And so in my area, it always feels like a recurring theme is that, you know, patients come in for symptoms that they have interpreted incorrectly, as we would say. So somebody comes in, my common situation is widespread pain. They feel like maybe somebody's overlooked a diagnosis and what have you. And as we look at this, we're thinking, okay, we're dealing with one of the other comorbidities as a predominant problem, and we've got kind of a submerged patient with lack of insight. And what I want to ask you specifically is whether you think it's appropriate to use some of these screening studies as a way to initiate the conversation with the patient, because Janet's exactly right. You have to leverage you have to leverage your relationship, and then you have to be kind of strategic about when you bring these subjects up. But I very frequently, you've heard us talk. You will use something like a SOAP to bring in the conversation about medication misuse or problems with medications, or a PHQ. Is that appropriate? I always feel like I'm trying to make objective data that helps a patient see things differently, or do you think it's more effectively just to rely on motivational interviewing and just kind of hang in there until the patient can hear it?
Well, I'm not sure there's one answer that fits everyone. What I would say is that if you frame it to the patient to say when they, this is assuming that, let's say you're seeing the patient, they're coming in and you're checking their vital signs, right? You probably are checking their pressure and their heart rate and, some of their vitals, maybe not all, but some of their vitals, maybe their weight, whatever the case may be. And early on in that discussion with them, or your staff can present it that way. This is a part of kind of how we check our vital signs, because we know in the world where we live now, people are under a lot of stress. You can use that generic term, a lot of stress. And so we don't want to miss something here, because we know that stress influences kind of your blood pressure, it influences your pain, it influences if you have heart problems or whatever. I mean, in other words, what you're saying to the patient up front is that we want to do a good job here, and that's part of us doing a good job to try to help you out. And because this is so common, we don't want to overlook it. We don't want to miss something that may be important. Now, I think those are for the basic screens. When you get into more touchy areas about medication misuse, as you brought up a screen for that, I'm not sure I'd do that the first visit.
No,
because you may damage that relationship. I think as Janet has nicely put, as you're starting to develop the relationship and the patient's coming back, you want them to keep coming back, then you start to introduce these are some other things that we want to stay on top of, or we want to cover this area because what I'm seeing here in the clinic, I just can't seem to explain what's going on. I can't figure it out. So I want to dig a little bit deeper and look a little broader and see if we're missing something. So I think then you get into the more kind of maybe what feels like intrusive tools, but that can be effective. But up front, I think it's that kind of broad. And the other thing about doing that is it gets them used to kind of thinking that way and saying, well, this is just how Dr. Massey does business. This is just what he does. And this is kind of normal. And I saw the people in the waiting room filling out some of these kinds of things as well. So then it becomes mainstream as well.
And I just kind of want to echo what you're saying with it. Absolutely agree. It becomes really important to add these screenings. And one thing that I found to be pretty effective is if a patient is coming in maybe with a particular complaint and you want to screen for multiple diagnoses and you're not exactly sure what it is at the moment, kind of removing the title of this screening can be really effective, and just kind of telling them, hey, I'm just kind of doing this because I want to see how you feel, versus if they see like ADHD at the top and it's like, oh, I really think I have ADHD. I'm maybe going to screen positive, and I'm not going to screen positive for depression because I don't think this is depression. And so just kind of keeping it open-ended, like, hey, just let me know how you feel. I'm going to give you a couple screening tests and we'll go from there.
Nice.
All right. Well, hey, thanks everyone for participating. We hope to see you back here in 2 weeks. Ed's got a talk on prescribing buprenorphine that I'm looking forward to. Keep an eye out for an email coming from me before noon today with a link to that evaluation survey, and we'll sign off now. Thank you.